Cheong, a clinical specialist from Hematology Unit, Department of Medicine. Welcome to Breakfast at UMHealth webinar. Thrombocytopenia is one of the common problems we encountered during our clinical practice. There are many causes to that. If we are able to approach the problem systematically, it is actually not as complicated as we think. Today, Dr. Shasha, our consultant hematologist from the Hematology Unit, will be sharing with us her insight on thrombocytopenia in hospitalized patients. Dr. Shasha has obtained her MBBS in 2008 and MRCP in 2012. She has completed Masters in Internal Medicine in 2015 and qualified as a hematologist since 2019. Without further ado, I would like to invite Dr. Shasha for a talk this morning.
Thank you very much for the kind introduction, Dr. Cheong. Let me just share my screen. Okay, so I'm Shasha, I'm from the Hematology Unit, and today I'll be talking about thrombocytopenia in hospitalized patients. So why thrombocytopenia? Well, I would say that 70 to 80% of our referrals will involve some sort of cytopenia. The most common one after anemia is low platelets. Thrombocytopenia is pretty common. This systematic review showed that in critically ill patients treated in ICU, up to 70% of them will have thrombocytopenia and 40% develop it during their ICU stay. 6 out of 8 studies found that thrombocytopenia actually increased the risk of death. So thrombocytopenia in very ill patients is not something to take lightly. So this would be a good opportunity to give everyone a bit of an insight to our thought process when we see a patient with thrombocytopenia. And also, I would hope to make aware of the bleeding risk and the indications for platelet transfusions, 2 of the most common questions we get asked. So these are the objectives of my talk today. I will quickly go through the definition of thrombocytopenia and then briefly go over the normal platelet homeostasis. Going over the causes of thrombocytopenia in hospitalized patients, looking at the platelet counts in relation to the bleeding risk, and lastly, looking at platelet transfusion and their indications. So thrombocytopenia is really platelet count of anything below the lower limit of normal. We can further categorize them into mild, moderate, and severe, with severe being platelet counts of less than 50. So platelet production is tightly regulated by the hormone thrombopoietin, or TPO. This is secreted by the liver at a constant rate. TPO acts on hematopoietic progenitor cells that causes them to differentiate into megakaryocytes. TPO then acts on the megakaryocytes, as you can see here, causing them to mature and produce platelets that you can see budding off these megakaryocytes. The bone marrow produces around 150 billion platelets per day, many of which are stored in the spleen. And once released into the peripheral blood, if you can take a look at this peripheral blood film, they are actually quite minuscule. Platelets last for at least 10 days in the circulation. Levels of TPO are regulated by the number of circulating platelets and megakaryocytes. When platelet level and megakaryocyte numbers are low, TPO levels are high and vice versa. Platelets, as you know, play an important role in primary hemostasis and maintaining vascular integrity. They are activated at the site of vascular injury to form a platelet plug that provides the initial response to stop bleeding. So what causes low platelet counts? A classical approach is to divide the causes into conditions of reduced production, increased platelet destruction, or abnormal distribution or sequestration. Although this table is pretty comprehensive and is what we normally teach medical students, it is difficult to use in a clinical context as most critically ill patients have more than one cause, and some disorders have more than one mechanism. So this is how we hematologists approach thrombocytopenia in a more clinical and practical sense. We combine important elements of history, physical examination, and laboratory investigations. First of all, it is important to exclude thrombocytopenic emergencies. Now, these are conditions, regardless of the platelet count, that need to be identified early due to their high risk of morbidity and mortality. So these are things like drug-induced ITP, HIT or heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura or TTP, patients in DIC, those with catastrophic antiphospholipid antibody syndrome, those with ITP with bleeding, and post-transfusion purpura. I'm glad to say that fortunately the conditions on this list are not common. Next, we will always ask for a peripheral blood film, and this is necessary for all patients with thrombocytopenia. We don't only look at platelets, we look at morphology of other red blood cells, as this will help us narrow down the diagnosis. For example, if there's presence of schistocytes, which is actually fragmented red blood cells, this raises the possibility of microangiopathic hemolytic anemia. If there are abnormal white blood cells or leukocytes, this raises the possibility of a hematological malignancy or myelodysplasia. We'll also consider the clinical context of which a patient is in. For example, especially in pregnancy, there are some conditions associated with thrombocytopenia that you don't see in non-pregnant patients. We will also assess the degree of thrombocytopenia. As I mentioned earlier, there's mild, moderate, and severe thrombocytopenia. So low platelet counts of the severe end, we would be a bit more concerned and would monitor closely. We will also look at the timing of thrombocytopenia. So how fast the platelet count actually dropped and within a certain period of time, that would help pinpoint the diagnosis. We will also look for signs of bleeding or thrombosis. Of course, bleeding and thrombocytopenia is more common, but there are conditions whereby thrombosis is more predominant. And these are conditions like heparin-induced thrombocytopenia. Sometimes bleeding signs are also absent, for example, in thrombotic thrombocytopenic purpura or antiphospholipid syndrome. So this table summarizes the common causes for thrombocytopenia in critically ill patients admitted to ICU and also their relative incidences. As you can see, sepsis tops the list, followed by DIC and massive blood loss. But it's important to note that thrombocytopenia in critically ill patients is often multifactorial. It is also a marker of disease activity, of which I will elaborate further. But before going into that, I'd just like to make aware of the usual pattern of patients with thrombocytopenia. Now, low platelets can occur in both surgical and medical patients. The pattern with surgical patients is more predictable in comparison to that of medical patients, as there's more heterogeneity in medical patients. In surgical patients, the platelet count will reach a nadir between days 1 to 4 post-surgery, and in a vast majority, the platelet counts will start picking up, reaching the pre-surgical levels between days 5 to 7. As you can see here, different types of surgery show slightly different patterns in terms of platelet count decrease and the time to reach pre-surgery platelet levels, but the pattern in a way remains the same. For medical patients, platelet counts, if they were to drop, will drop in 90% of patients within the first 5 days and will start coming up and normalizing from day 5 onwards. Now, almost all studies looking at thrombocytopenia as a prognostic marker found an inverse correlation of platelet count with the risk for prolonged ICU stay and mortality. And the mortality rate ranges from 30 to 40% in thrombocytopenic patients in comparison to half of that in non-thrombocytopenic patients. The degree in which the platelet count decreases correlates more highly with adverse outcomes than the absolute platelet count itself. And it has been shown that a blunted or absent rise in platelet counts in critically ill patients is associated with increased mortality. As you can see here, this graph is taken from a paper published in 2000, was done by a team in Netherlands, whereby they looked at all the patients admitted to ICU over a 7-year period. So what you can see here is the white circles represent survivors, the median trend of platelet counts for survivors, and the black circles represent the median trend for non-survivors. And as you can see, this both cohort of patients started off with a platelet count that is almost similar. However, from day 2 onwards, you can see an increasing trend of platelet count, which in the end is significantly higher at day 10 in comparison to non-survivors. The non-survivors, as you can see, consistently had a lower rise in platelet count. So let's look at the bleeding risk and low platelet counts. And this really is the primary concern of any doctors dealing with patients in hospital with thrombocytopenia. Unfortunately, the relationship between thrombocytopenia and bleeding is not well characterized. With the exception of very severe thrombocytopenia, I'm talking about platelets of less than 5, in most cases, other factors collectively contribute to the bleeding risk. Studies looking at bleeding risk in thrombocytopenia are mainly derived from platelet transfusion trials, mostly in oncology patients with chemotherapy-induced thrombocytopenia. There are very few studies out there looking at thrombocytopenia and bleeding in non-oncology patients. So this is really my take on how I assess bleeding risk in a patient with thrombocytopenia. So first of all, looking at the platelet count. Now, the numbers shown here are derived from trials evaluating platelet transfusion thresholds in patients with chemotherapy-induced thrombocytopenia. And it has been shown that severe spontaneous bleeding is most likely with platelet counts less than 20, and especially less than 10. I will also look at the disease the patient has, as well as if the patient is about to undergo a procedure. Of course, you need to look at the bleeding risk of the procedure itself. Generally, patients who are about to undergo a high bleeding risk procedure and have low platelet counts, they can be considered for prophylactic platelet transfusion at a higher threshold, or even postponement of the procedure if it is an elective case, until the count recovers. For those with low bleeding risk, sometimes, actually in most cases, you can forego prophylactic platelet transfusion. Also, most commonly, patients who are undergoing chemotherapy or stem cell transplant in a hematology unit will be more concerned if the platelet is less than 10. And also patients with chronic liver disease, for example, they are also at an increased risk of bleeding. I will also take a look at whether there's actual bleeding ongoing. So bear in mind that patients with mild or moderate bleeding and thrombocytopenia can actually evolve to having severe bleeding. So these patients will really need to be monitored closely. Of course, it's important to identify the site of bleeding if it does occur, and to stop the bleeder. Lastly, I'll look at whether there's a history of bleeding before, and this is mainly relating to inherited platelet function disorders or hematological conditions. And I will look at the platelet count at which the bleeding happened in the past. That would be important. So we move on to the next frequently asked question: can we transfuse platelets for this particular patient? So before I go into that, I would like to talk about how platelet units are produced quickly. So platelets can be prepared in 2 ways. We have platelets from whole blood component, whereby a donor comes in, we extract whole blood from them and centrifuge the blood and separate them into different blood components, red cells, platelets, and fresh frozen plasma. And you can get random units or pooled platelets through this method. There's also another method of using a platelet pheresis and apheresis machine, whereby a donor comes in and whole blood is collected, but only the platelets are retained and the remaining elements are returned. So apheresis have the advantage of limiting the recipient exposure to a single donor. We also call this a single donor platelet. At UMMC, apheresis and pooled platelets undergo leukocyte reduction, and this is to prevent febrile non-hemolytic transfusion reaction as well as HLA alloimmunization. Platelets are stored at room temperature between 10 to 24 degrees, which is why their shelf life is only around 5 days. Transfused platelets only usually circulate with a lifespan of around 3 to 4 days. So, right. So how much of platelets would you give a patient? So the standard dose for prophylactic platelet transfusion is 1 whole blood donor unit per 10 kg of body weight. So for example, if you have a patient who is 50 kilograms, so that patient would require 5 random units of platelet. 1 apheresis unit or 1 whole platelet unit contains 4 to 6 units of whole blood donor platelets. So at this therapeutic platelet dose, the platelet count is expected to rise by 30 within 10 minutes of infusion. So it peaks at 10 minutes to 1 hour, and it gradually declines over 72 to 96 hours. Another thing to note is that platelets account for the highest number of transfusion reactions. Yes, red blood cells are the most common blood component transfused, but platelets cause the most problem. So the most common transfusion reaction would be febrile non-hemolytic transfusion reaction and allergic reaction. Sepsis from bacterially contaminated platelet unit, although as you can see here, the frequency is quite low compared to the other two. It is, in comparison to all the other blood components, it's the most frequent infectious complication between all the other blood components. So what are the indications for platelet transfusions? As you can see here, there are many guidelines that will help you to make informed decisions when it comes to platelet transfusion. And these are the guidelines that I've derived the next few slides from. And I urge you to look at the guideline that is suitable to your field of practice. So the first indication would be prevention of spontaneous bleeding in afebrile patients with platelet counts of less than 10. Many randomized control trials have been done. I've taken one of the largest, which is the 2013 TOPS trial. It involves 600 patients receiving chemotherapy or undergoing stem cell transplant for hematological malignancies. And the patients were assigned to either to receive or not to receive prophylactic platelet transfusion when the platelet count is less than 10. And as you can see here, there's a higher incidence of major bleeding in the no prophylaxis arm, 50% versus 43%. So this is why most guidelines are unanimous in recommending platelet transfusions in patients with platelet counts of less than 10. The next indication for platelet transfusion will be in preparation for invasive procedure. So these are the recommended thresholds of which to consider platelet transfusion. So for low bleeding risk procedures, for example, central venous catheter insertions, dialysis access catheters, you would want a platelet threshold of 20 and above. For high bleeding risk procedures, for example, deep access drainage or solid organ biopsies, a platelet threshold of 50 would be ideal. Major surgeries, for example, cardiothoracic surgeries and orthopedic surgeries, you want a platelet threshold of 50. For neurosurgery or any eye surgery that involves the posterior segment, you would want a higher platelet threshold of 100. Of course, there are some areas of contention when it comes to certain procedures, as you can see here. And I would normally tend to err on the side of caution and go for a higher platelet count when it comes to these different platelet thresholds. In actively bleeding patient, you should consider platelet transfusion if the platelet count is below these recommended thresholds. So for patients with severe bleeding, we would aim for platelet threshold of 50. For those with traumatic brain injury or spontaneous intracranial bleed, a platelet threshold of 100 is ideal. And for non-life-threatening bleed, we would aim for a platelet threshold of 30. So these are relative contraindications to blood platelet transfusion. There is no absolute contraindication. We would still transfuse platelets for these patients, especially if, for example, a patient with TTP has a platelet of less than 20 and requires a catheter insertion. But these are mainly immune conditions, and actually it can worsen certain conditions if you give platelet transfusion. So in summary, thrombocytopenia is a frequent finding in hospitalized patients. Please remember that severe spontaneous bleeding is most likely with platelet counts of less than 20, that means very severe thrombocytopenia. Platelet transfusions is the most common cause of adverse transfusion reactions. So judicious use of platelets is advised. And I hope that everyone is more aware of the indications of platelet transfusion and platelet count thresholds for certain procedures. Thank you.
Thank you, Dr. Shasha, for the very interesting talk. I think we have two questions in the chat box. Number one, would platelet function be a useful parameter to determine risk of bleeding than the numbers? As platelet function become an easier parameter to monitor?
Sorry, Dr. Cheong, I didn't get your question.
Yeah. There are two questions. Number one is, would platelet function be a more useful parameter to determine risk of bleeding than the numbers? And has platelet function become an easier parameter to monitor in terms of the platelet function?
There are many tests for platelet function. Are you talking about platelet aggregometry tests and all of that? Platelet function, we would normally perform for if we are looking at things like inherited platelet dysfunction disorders. And also bear in mind that certain platelet function tests would not be accurate because of the low platelet counts. So patients in more severe, in the more severe category, all these platelet function tests will not be very accurate. So, well, it depends on a case-by-case basis, I guess. But for the majority of patients, non-hematological patients, we would not perform a platelet function test.
Okay, the second question in the chat box: how safe is platelet transfusion to cover risks of bleeding in patients needing regional anesthesia of the spine?
Okay, regional anesthesia. So, platelet transfusion thresholds. It also depends on the cause of the thrombocytopenia in the first place. So, and of course, you will advocate a platelet level of 80 and above. And so far, from my experience with the usual patients with immune thrombocytopenic purpura, who are pregnant and opting for epidural anesthesia, the outcomes are good with platelet transfusion. It's not really an issue. Yeah.
All right. So far, I think there's no more question in the chat box. If there's any question, please feel free to type in. If there's none, then for the interest of time, then I think we can proceed with the second topic for today. I would like to thank everyone for your attention. Thank you.